Kia ora koutou. Welcome to eHealthTALK NZ. Today I'm joined by GPs Dr. Richard Medlicott and Dr. Karl to talk about the use of AI-powered medical scribes in primary care in New Zealand. We talked to Karl and Richard a year ago when they were at the start of their journey using the technology during consultations, so it's time to check back in to see how things have changed and what they have learnt over the past 12 months. So welcome on the show to both of you. Can you just start by telling our listeners when and why you started using an AI scribe in your practice? Karl, do you want to go first?
Yeah, well, it's a year ago. That's amazing, isn't it? I started just before then, and I must say I use it by default now. My patients expect it. They ask me how it's going when they come in, so the consent's a lot easier. I remember to consent new patients, but I've actually started using it for much more than just scribing the consult. It's the letters we write and things like that. So 18 months ago, I'd say I probably started using it. I've moved between some products, streamlined my layout, and it's now part of routine care for me. Richard?
Yeah, look, you told me about it first up at a conference, Karl, so I got onto it fairly quickly and have used a number of different products. Um, I'm still using it pretty much the same way I have. It's summarizing the notes for me. What's different, I guess, I'm using a product that I'm helping develop, so it's integrated into MedTech, so that's quite cool and gives us avenues for future development, which we might talk about later. Got more of my colleagues using it. Like Karl, there are tools for writing letters and so on. I use it at the After Hours Medical Centre. So it's better than it was. The AIs are getting better at summarizing. There's a lot of competition out there. It's becoming commoditized. So it's how you use it for the next steps. And look, most GPs aren't using it at all. I'd encourage them to start thinking about it.
Great. So a recently released AI in primary care survey has found that 68% of respondents now use AI tools, which was up from 52% in the first round last year. So notably, daily AI use has risen from 25% to 40%. Does that align with your experience personally and of colleagues increasingly starting to use the technology as well?
Yeah, absolutely. You're seeing a whole lot of interest, and it's very understandable why people are doing it. And it's the usual adoption curve, isn't it? You've got some initial people who start off, and then you get a bit more of a groundswell and behind it and a fast uptake. And I suspect we're still in the fast uptake stage. And then you get some people who are not keen and will take quite a while. It'll be fascinating to know how many minutes, hours, weeks, days, probably years of GP time and nurse time has been saved through using these tools.
Mm. Do you use it for all consultations now?
Yep. Occasionally I forget to switch on the microphone, which is always annoying. But here's a top tip. If you do that, just restart the microphone, talk through the consultation. And I do this for when sometimes the AIs don't do a great job, just sometimes, especially if actually the consult hasn't been great. Rubbish in, rubbish out. If it's been a meandering consult and thinking, what the hell is going on? It's very hard for the AI to understand what's going on as well. So at that stage, scrub it, go back, talk through what you thought was going on in the consultation. The patient came in for X, Y, Z, and B, G, Y, and all the other things. I did the examination. I found this and that. I think this is going on, plus a bit of this and that. And the plan is to do this. And so you can talk to it in natural language, and then it pumps out a really good soap note from that. And I know we're digressing as we tend to do on these podcasts, but I think that's probably a really good thing for the registrars to do as well. I'm a bit torn as to, we're experienced GPs, um, and I feel I don't need to more practice in typing up notes. In fact, my pre-AI note taking wasn't great. But sometimes there's a thought process that goes into typing up notes. And I think maybe registrars shouldn't be using the full listening to the consult, but listening to them at the end of a consult where they've formulated what's going on. So I think that would be that would be a good step for maybe doctors who don't want to use the full listening to the consult option.
There was a big debate I got into over the exact thing. that writing is thinking. And I got, almost offended because I'm a very bad writer, surface dyslexia, and think around in concepts, and that's why I like IT so much. And, I can say it, writing down's a bit more of an effort, but I can think it. I've got the formula in my head, and I can take the story. And I was always told you're just a bit lazy, you're just not writing it. But it's just more of an effort for me, and I get too bored. And I can say it. So the whole hyperlexic world that you have to write to think, I found very offensive, because there's plenty of very smart people, engineers and surgeons also, who don't write that well, but think very well and can formulate it. So I think it's a great tool for that side of things too, because say I've done handovers to registrars in hospital going in, and I thought I'd do what you said. I'd let it record and dictate it, and then I said, make that a handover note, and it writes a beautiful handover note. But what we actually had was a discussion back and forth with the registrar about the patient coming in, but it summed it up in a beautiful structure. So, is that thinking? Perhaps it is. It's a skill, but I don't think all writing, we're saying if you don't write it, you're not thinking, which I think is way too simplified.
Mm. Yeah, I hadn't thought of that. And I know you're saying, there's always an adoption curve, but obviously with IT, often clinicians are resistant to adopting. Whereas, within a year, you've got 68% of respondents to this survey saying they're using an AI tool. I mean, that is a pretty fast adoption rate and tells you something about what the technology is delivering, that they are willingly starting to use this, do you think?
That tells you more about what the problem was there, and the problem that's unrecognised, and the problem that's getting deeper. The problem of too many forms, over complexity of interface with the forms, and taking our attention away from the patients. So people didn't do it for the AI. I certainly didn't do it for the AI. I did it for the fact it gave me, it solved the problems for me.
Yeah, I had a conversation with someone I met just the other day. She was talking about how she loved her GP using it because, and I've heard this before, because the attention was on her, and she really doesn't want the doctor typing away. I mean, I was always someone who typed up at the end of the consult, and I'd be pretty tired moving into the following consultation because of that cognitive load. But there's something really important here about paying attention to the patient and giving the patient your attention.
The survey also found that GPs and nurse practitioners are the primary users, followed by practice managers. I was interested in that. Is that similar to your experience?
There's a group of specialists that are using it in various areas and have seen how good it could be, and are using it for reminders while still using the current system dictate. I've shown cardiologists, once they start getting into the templating side, they didn't realize, and they've got a massive problem of having to fill into 5 different places to log in, sign here, get a template from there, get the report from there, and do there. And between that and some other solutions I gave them, it's saving them hours a day. When you've got highly structured reports to dictate, echocardiograms, results of investigations, it's where it's brilliant, and no one's applying it to those very bespoke areas. And the sphere of AI is sort of stopping them do it in its useful areas because it's got some problems in other areas. But no, I know of a lot more than primary care, because they all see the usefulness of it, especially when they've got structured reports.
Hmm. You mentioned this before about the patient experience, Richard, but has using an AI-powered scribe altered your experience of being a GP and the care that you're able to provide to patients?
I'm less tired. That's the key. Um, uh, I've talked about it before, just that cognitive load. We have very intense interactions with patients with complex and complicated conversations. And then we have to come up with a plan, and that's the crux of what we do. And then you have to document it. And so when you're documenting it and you've had 15 minutes and you might have had 3 problems, you have to remember and then write it down. And that just takes work. And then, okay, I've done that. And then I'm up, next patient, down the corridor, bring the next patient in. You just don't get a rest. And so your brain doesn't get a rest over your session. So the ability to sit back, see the note being structured by the AI, and reading it and reviewing it and altering it, that's really key. It's still key and always will be key. Just is much easier. So I'm more refreshed. That's my key difference.
Hmm. And presumably happier got more time
Yeah,
for
well, I'm always a pretty
other
happy kind of
things,
guy,
or
so
what do
I
you
don't
do
get
with the
too
time you
unhappy.
save? Does it go back into the practice, or do you,
Um,
if you found you got a bit more time?
yeah, mountain biking. I like mountain biking, DIY, mowing the lawns, going for a snorkel. I'm not seeing more patients. I choose not to see more patients. What I have done though is for um, a couple of sessions a week, I now do remotely. So with the AI listening in, that's a slightly different e-health issue. This is the IT telehealth, but it ties in nicely with the AI.
What about you, Karl? What's your experience been? I've heard some people saying, they've talked to GPs who said, I was going to retire and I haven't retired because of this. Do you think it's that
I
extreme
was
in
going to
terms of
retire
the
10 years
impact?
ago, and I think I got sucked into. I enjoyed being with humans, and I was saying that to the Minister of Health yesterday. Doctors and GPs and medical practitioners went to medical school too, but we sort of get forgotten about when the hospital-centric world looks at organs and describes disease. We've got more and more siloed. It's back to paying attention, enjoying knowing people. And as Richard said, they come in and look you in the eye and say, thank you for that. When my father died, it was right what you said, and that helped him. It was a comfortable death. And you're typing away, go, okay, yeah, good. Oh, thanks. It's just not the same experience. And people say they can touch, type, and look, but they don't know what it's like to not touch the keyboard for 10 minutes. And it's a much more human experience. I'm also finding I've played with some short consult notes for doing quick follow-ups when we've had some high stress in the practice. We've had a couple of times where a doctor's away and one doctor had to go back to India. So no notice. So I went from a full clinic, full books for 3 patients, 3 doctors, to just myself at 8:30 with 15 minutes notice. So we managed to get through about 40 walk-ins plus my list with the nurses, predominantly by using AI to assist me doing short notes summaries for what could be done later, and we called what we decided, and it got put in by them. So we sort of worked as a team. So it's another tool in the tool belt when the situation's changed. So it's changed the experience on normal days, and it's also given us an extra way to kick up a gear if you have to. One other last thing is I've been playing with and experimenting after hearing the nurses come back. The best thing about the AI is they can understand my notes, what the patient was negotiated to do next, what was the expected plan, what was going to happen if it doesn't work, is what they enjoyed the most, because the patients are ringing in and say on the script on the portal. So I've made a template that explicitly goes through and step by step in clear language, based on the transcripts language, the reading age, and write it in a very clear way what the worsening symptoms are expected and what the next steps are expected by which time, and it extracts all that out. And that's been the most useful thing, because then the nurses know what we expect. We don't always put that in our plan. We always have a very medical plan. So having that much more detailed has turned out to be a great thing.
What about you, Richard? What have been some of the key lessons you've learned to get the most out of an AI-powered medical scribe?
I think going back to the basics of ensure that you read what it's written. You can do some really fancy stuff that Karl is talking about, like adjusting your prompts and so on, but use it. Be clear when you're talking. It helps to try and be. It's good at picking up unstructured conversations. That's the magic of it. But talk through your consultation. Say, well, your blood pressure is 135/60. Your heart sounds are normal. Your chest is clear. I'm examining your abdomen. I can see you're a bit tender down in the lower left of your abdomen there, but there's no what we call guarding. So I don't think there's anything too bad going on. So talking through the consultation. Sometimes, especially if it's been a complex one, and you should do this, it's good practice anyway, is kind of summarizing to the patient what we've talked about today and what the plan is. The AI chances are, it'll pick it up anyway from the conversation, but it's good practice to do that for the patient, and it does make it easier for the AI.
And Karl, what advice would you give to a GP who's thinking of using a scribe in their practice? How should they go about selecting one and implementing it, taking those first steps?
It's nothing like just practicing. You can practice with dummy runs and then push the template and then see what kind of thing comes through. And I think Richard's advice last year, talked about having a a very smart, hyperlexic medical student who's blind in the room, writing everything down is the way you sort of think of it, and you realise, oh, I've got to say that out loud for it to write the exam findings. Then practice with the templates. The templates make a huge difference to your style if you do that. We're under such time pressure, learning on the job is very hard. So they want to practice that. And then let people know, and it'll be, people they'll get much more interested in it when you tell them I'm trialing this. And worst case, if it's recording, it comes out and you don't know what to do and you don't like what it's done, you can just go back to your own, nothing stops you writing your own notes. I've got used to, I don't know if you do this, Richard, I just dictate, and I ask the dictation to be the summary or get it to clean up the summary. On the tool I'm using right now, you can actually give it a few instructions afterwards, say, ignore that, emphasize this, and away it goes.
Richard, I think you said patients are happy and they're interested in it, but is there any other feedback you've gotten from patients? And also, how are you approaching the issue of patient consent these days?
I shall talk about the patient experience first. So, yeah, they like being the center of attention and not distracted, but not having me distracted by the computer. I've had comments back that when they read the notes on the patient portal, they prefer what the computer has written rather than what I have. The consent is interesting. So we did probably 1,000 patients consenting at Island Bay, and no one said no. We talk in general practice about the opening gambit, the first things that you say as part of your consultation. It might be, hey, how are things going? How was your trip to Vanuatu? Or how's your mum getting on as you're walking down the corridor? Or anyway, it's the opening gambit. And it sets the scene, it sets the tone, and I have issues with those who say we need to consent every patient every time, because I think that's interfering with the patient, with that opening gambit. And it's also a little bit unrealistic when we're not putting the same consent process around actually far riskier information sharing that we do with every consultation. Every day that there is identifiable patient information with problem lists and medications going to physiotherapists, going to the PHO, and we've had a number of PHOs get hacked. There's a whole lot of identifiable patient information which is shared every day, probably 10 different silos per consultation. So we're getting, and I understand people's sensitivities about the new thing, but actually I trust whichever of the large LLMs, I trust them with this data far more than I do the physiotherapist down the road who I did that referral to. So it is important, but we felt we had some social license of not asking patients each time. But with our text reminder for appointments, we have a link to our webpage which says what to expect in consultation, which includes talking about the AI. We've notified people through the portal, which goes to about 3/4 of our patients. We have signs up in the waiting room, and we have it comes up on the TV rolling stuff. So we inform people that we're doing it, but we're just not consenting each time.
On that note, Karl, there has been a lot of discussion regarding data sovereignty and the use of AI scribes that are hosted overseas. What are your thoughts about private patient data leaving New Zealand in order to be transcribed?
I think people got to be aware that the world doesn't have little nice boundaries and geographical locations. New Zealand, we've got a real naive idea, because we're an island nation, that we've got these boundaries because people can't just walk over the border. The internet doesn't respect your international boundaries. The internet doesn't care about your little administration organizations. The internet is set up to not give a rat's about your boundaries. So we try and put these boundaries up for secure rights, but in reality, as Richard, maybe your presentation last year, followed through just one consultation on where information is going into radiology systems and other systems, which are international companies. It's called a web for a reason. It's more about the process around it than the actual location. The physical location these days with data centers and the rest is almost irrelevant compared to the security, the auditing, the trust, the accountability of the processes around protecting it.
And I do understand that these scribing tools are now widely used in other areas of the community, such as allied health and aged care. Have either of you seen the use broaden beyond general practice and community care?
Yeah, I've seen letters coming back from consultants where they state they're using tools to write the discharge letters or the clinic letters. I'm aware of a friend who is using one of the tools actually in a public hospital. Physiotherapy is probably a bit naughty because they're not supposed to.
Mention the name. Don't mention the name.
Yeah, no, I will not mention names, but he's taking consent each time and saving a huge amount of time as a result. So look, people are using AI in all walks of life. And just this morning, I'm doing a work on COPD with the HQSC, the Health Quality Safety Commission, and we're just looking at creating an audit for general practice around COPD. So I asked Copilot, write me a quick audit on COPD in 300 words. Gave a beautiful audit with suggestions of things to look at. Then it gave follow-up questions about why are these questions important or what kind of data you might want to collect. And it took 5 minutes. So, of course, people are using them in all walks of life.
Mm. And Karl, what do you see as the future in this space? There is a lot of talk about agentic AI, where the scribe would be linked to the electronic health record, be able to make suggestions and take actions such as ordering a blood test. Is that where the future lies, do you think?
Yeah, I've been testing and reading a lot about them. And I'm looking at some studies where we could do it to help both practice level cohort targeting patients that you kind of get in a more traditional X plus Y kind of query way. All people have got a box here. We could actually look for other patterns and predict people who might be more of CVD risk to get the actual more formal CVD risk assessment, because we just use age at the moment, right? So there's that kind of thing coming along, which is very smart. I always debating with them. They think we've got all the information you'd need about a human to be able to identify them, and they don't get that. A lot of the IT guys come along and we have to explain to them we don't have a lot of stuff that we should know about these unknown unknowns. So you won't have a perfect model from our data, but there's a lot of data in there that you probably will be able to do things we didn't realize. As for nudging me in the right way to give me the right ACE inhibitor in this situation, because this one's slightly better than that one, would probably find annoying, but it might actually be very useful to say an ARB is better than an ACE in this kind of particular case with this heart failure and this. And I think they're going to be explode and very helpful in primary care for that multi-comorbid, multi-problem patients. And I'm already using it for some of those situations. People have got some very poor outcomes handed over very badly between services. They might be diabetic, heart failure, get bowel cancer, and they get a high creatinine from being dehydrated. 6 people trying to adjust their conditions, their medications, having someone help me be the multi-specialist one-agent advice that can go across those guidelines, and then let me stay up high and watch the whole game and direct, they're going to be invaluable. So it's Perplexity is one I've been using. A lot of registrars apparently using Perplexity, designed exactly for this, open evidence, very much targeting this kind of clinical question, what I do in this situation. And it's always got sources and good sources you can read through. The other area is around wearables, and we're working on a blood pressure wearable that's continuous monitoring that will help us titrate and predict people's type of blood pressure based on 24-hour continuous blood pressure monitoring. So looking for patterns and those things we never thought we could do before suddenly be helpful for us. What will happen is that combined Copilot helping you become better at assessing the situation coming up for compromise before in the patient-centered way, and possibly do things like better preventative healthcare for blood pressure titration using support and summaries from agentic AI. Has been watching someone for 2 weeks with continuous blood pressure, sleep, and come out with a report. And I think we're going to end up bypassing the hospital for that. I think the opportunity around the world is definitely very disruptive to the old style of waiting for an outpatient visit for this problem.
On that, AI agents, one of the things is that for GPs like Karl, it's fine going outside and using these external tools, but you need the AI to be integrated with your PMS, and that's a little plug for the company I'm working with IntelliTech Health. So we've worked with Medtech. AI is integrated with only little integration so far, writing the notes, inserting blood pressures and weights and heights and so on, so inserting the vitals. But because we're using Medtech's Alex API, we can get access to all kinds of stuff within the medical record. And we've rolled this out with Telstra in Australia, and we're working with other, we're working internationally. And so the idea is that, yes, the AI can look at the record and give you suggestions or just summarize stuff. I played with downloading my own personal health record this morning and putting it into Copilot and saying, hey, just summarize my medical record and give me any insights into my health. And it was really good. Then it becomes, where does the AI go in terms of not through the doctor, but these should be linked through with the patient portals. The patient portals have a heck of a lot of information for patients. And so why are we titrating the blood pressure? Actually, the direction of travel is going to be faster and more profound than most people think. There are estimates that by 2030, 50% of thinking jobs could be gone. That comes out of Kinsey. So we're up for a radical reshaping of society, and we have to start to think about to whom accrues the profit. What do we do about universal basic income? So we're just on this podcast talking about a little wee fraction of what's coming our way, but it really is quite remarkable. Buckle up. It's going to be a hell of a ride.
And so just finally, do you think that New Zealand's public health system is taking advantage of the benefits of AI can bring, or as Karl said, are we falling behind somewhat?
Yeah, I think the New Zealand public system is falling behind terribly. We've got an issue with a roadblock in terms of tools being approved, and a little bit opaque of how tools get approved. The idea that here general practice is 2 years into the AI revolution and it's hardly touching the public sphere, and I'm seeing the time that my hospital colleagues are taken to write up, say, a psychiatric note, the pages you get from one outpatient appointment, they are wasting huge amounts of time, and they need to get on with it and get it integrated into the public system.
I remember when the cloud was scary. No one wanted to use the cloud. Oh my God, the cloud's going to take all the data. It's not the tool itself. The process is to define the problem, look at the business process, what can be productively increased. And now these tools have opened up more tools. It doesn't mean we're being really far behind. One of the psychiatrists was talking about ADHD, massive embarrassment that it is in New Zealand and the access, where less than 90% of the expected rate of Samoan girls have got any kind of assessment of Ritalin, and less than 50% of Maori girls, but 90% of white boys have got Ritalin at the rate we expect, about 3.5%. We haven't got any kind of thinking that we need to improve the access process other than just more workforce, which we are not going to get. In other places, this kind of time pressures let them think about how to safely get through the 80% diagnosed, treated, and then followed up, and work on the difficult 20% rather than stopping everything and not letting anyone through until we get a perfect solution, which is another 1,000 psychiatrists, which ain't going to happen.
Right. Well, on that note, thank you for joining me today, Karl and Richard. So it's been a fascinating discussion. Again, if you are interested to learn more about AI and health, you can check out the upcoming HINZ Summit on this topic. It's being held in Wellington, May 20th and 21st, and you can find the details under events at hinz.org.nz. So I look forward to seeing you there and carrying on the conversation as the use of AI in health develops. Mā te wā.